Can you identify with the following scenario? A patient arrives in the emergency department and presents with apnea, secondary to either trauma or an overdose of narcotics. An arterial blood gas or ABG analysis is ordered soon after the patient is intubated and placed on the pressure-regulated volume control or PRVC mode. You proceed to procure the blood sample and run the gas. Usually, that initial ABG report will prompt you to modify the ventilator settings in an attempt to mobilize the arterial PCO2 and the arterial PO2 readings closer to the homeostatic range. This 36-minute module outlines a strategy for identifying a suitable target PCO2 based on the prevailing arterial carbon dioxide tension, the bicarbonate ion concentration, the tidal volume setting, and the respiratory rate setting. By employing this strategy, the RCP can select new settings, which will predictably result in an arterial carbon dioxide tension which is close, if not precisely equal, to our target. By adding this methodology to their clinical skills inventory, RCPs will enhance the care of their mechanically ventilated patients while consolidating their role within the ED and ICU teams. To our knowledge, the physiologic basis of this logical and systematic method is not available anywhere else. And to the extent that you might encounter a physician colleague who challenges you to validate your strategy, and here's hoping that you do, a detailed mathematical derivation is provided which verifies that the simple formulas upon which this approach is based are physiologically sound. Whether we like it or not, and whether we're aware of it or not, the other members of the ICU team harbor certain expectations of practicing RCPs. For example, RCPs are expected to perform percutaneous arterial punctures, assist at flexible fiber optic bronchoscopy or FFB procedures, assist at crash intubations, assist at closed thoracotomy procedures, assist at thoracentesis procedures, insert arterial cannulas, and perform bronchial biopsies in the presence of physician bronchoscopists, to name a few. But the core of any RCP's practice is the interpretation of ABG reports and the expert management of the mechanical ventilator for intubated patients. To the extent that we're able to determine the PCO2 target value for a newly intubated patient and to rapidly attain that target, we will consolidate our role as high-achieving members of the ICU team.